Welcome all to our very first TB Think Tank webinar session for the year 2025. And we are excited to announce that our webinar sessions are now CPD points accredited. And so for this session, this session is titled First National TB Patient Cost Survey, Findings and Recommendations. A brief introduction to today's speaker. Mr. Don Mutsengi is a health economist at the Aurum Institute who has extensive experience in costing and economic evaluation of public health interventions. His research focuses on the economic evaluation of TB and HIV interventions, case detection, and optimizing resource allocation. He currently also chairs the TB think tank's epidemiology, modeling, and health economics task team. His involvement in public health research spans multiple countries, focusing on TB preventative therapy, contact tracing, and new TB drugs. He's currently managing a global clinical trial aimed at evaluating the safety and efficacy of a shorter TB drug regimen. Additionally, he's pursuing a PhD at the University of the Witwatersrand, where he is exploring the use of mobile health technologies to enhance TB contact tracing. I'll hand it over to you, Mr. Don Mutsengi.
All right, thanks, Nolozi. I will just share my screen now. Tell me if you can see it.
Yes, we can.
All right. So just to acknowledge the Dr. Mvusi and Dr. Nkateko Mkondo. Dr. Mvusi is from the Department of Health, and Dr. Mkondo is from WHO. And I'm from the Aurum Institute. So this work was also presented on the 17th of July on Knowledge Hub. So they've been kind enough to allow me to use the same slides. So starting with patient costing, this is part of the key global indicators and milestones that are in the NTB strategy. And the target here is by one of the three main targets of this, and you can see that it is on the Sustainable Development Goals and also the NTB strategy that by 2025 we needed to have zero catastrophic costs, that is costs that debilitate and push patients into poverty. But it seems we have missed that, but we have made some efforts in trying to get there. And this is TB-affected families facing catastrophic costs due to TB. So how this started is that in 2015, WHO convened this task team to develop a generic protocol that will be used to collect the TB patient costs. And there are a couple of countries that have already done these surveys, and in 27 they came up with a patient cost handbook, which is like a protocol for guiding how to conduct a TB patient costing survey. I think another one, a second guideline, will be out sometime this year after some revisions. But to the objectives, there are a couple of objectives, 4 objectives that are mentioned in the handbook. The first one, which is probably the most important and what people want to hear the most, is about documenting the magnitude and drivers of the different types of costs that TB patients incur, and also their households. It's key to include households here because costs are not only incurred at the patient and individual level. And this will be used to guide policies to reduce financial access barriers and also minimize adverse socioeconomic impacts of TB. But also there are other objectives, that is after having done this, you then determine the baseline of TB costs, and then you periodically measure these costs. And then also we wanted to find the correlation between costs and different thresholds, and if these are sufficient measures of measuring catastrophic costs, and also quite important to determine the association between these costs that patients incur and also the treatment outcomes. That is, is there any relationship between high costs and poor outcomes, or the other way around? But why should we focus on this economic burden? Why should we care about TB patient costs? Because many TB patients suffer from huge economic burdens, even under the free TB treatment policies. It starts with poverty. And then what it does, it also causes barriers to early diagnosis, causes treatment interruption, and it impoverishes people and increase their vulnerability to TB. So these costs are what patients pay through transport to go to the clinic. And remember, these costs, they begin way before they are actually diagnosed. And as you will see here, the costs are structured like this. There is a pre-treatment phase where a person is seeking care, and at times they have to go to the clinic multiple times until they are diagnosed with TB. And then they start treatment. And after starting treatment, they also have visits to the clinic, inpatient and outpatient care, medical and non-medical costs. Medical costs, at times they have to, even though we have free treatment at the clinics, some patients would also choose to go to private because of the sickness that they will be facing, and they will pay out of pocket these expenses for consultations, for drugs, and so on. Some would have to buy additional food because of the disease. And then one of the biggest is income loss, because they have not been able to do any work, especially as I've said that many of the patients are poor, and most of them are not working, and some who have informal jobs would have a lot of income loss because they're not able to work. So all of these costs are what we call patient costs, including the saving, where they have to reduce some of their savings as they're trying to cope with the cost that they're experiencing because of TB. So these costs are experienced both in the intensive phase and in the continuation phase, the same cost. So we divide them into direct and indirect, and these are the direct, and then the time losses are called indirect costs. But just again, coming back to this, when we measure these costs, we come and measure at this point early on into the intensive phase, and then we collect all the costs that they were incurring during this intensive phase. We even uh, collect retrospectively, as far as they can remember, about the same direct costs that they are paying, and medical, non-medical, and then also income loss. Um, and we also do the same for patients that are in the intensive phase. We go into the intensive phase, early on into the intensive phase, and then we collect costs from this point onwards, and then everything that is not collected before this period, it is estimated using the costs of the people that we would have collected for the intensive phase patients. So the indicator that I have presented in the second slide, it adds up direct medical costs. This is money that is paid directly to healthcare services. They can go to a pharmacy, they can go to a doctor. Many go to traditional healers, and then they pay for these amounts. And then there are non-medical costs. This include transport, they include food. At times you get people that have to go to hospitals, and then they're admitted in hospitals, and some of their relatives actually have to rent or book accommodation close to the hospitals, and then all of that, it is collected. We also collect if a household member loses time as well, we collect it under indirect cost, because now the person has to go to seek care with the patient. They're also losing time, and time is value, which is money. Also the indirect cost of the patient, because they could have been doing something very productive. And then our denominator becomes annual household income. So we add up the income of everyone in the household, the patient, if they are working, and other household members. And if this fraction here shows that 20% of these costs are taken from the household income, it is considered catastrophic. Catastrophic because they have to replace sometimes school fees, sometimes expenses for the family. And remember, these are people who are by default, many of them rather, not by default, but many of them are poor. So if they have to replace 20% of a very low income, that is clearly catastrophic. And it will cause a lot of other consequences. I would choose not to go to the clinic because I have to pay for my child's school fees. I have to buy food for the family. Or whoever is the household member or whoever is the breadwinner in the household, maybe they're not the patient, they will choose to say, well, this is too much money and everyone else cannot suffer. So there are some of those things that will then lead into poor outcomes. And that's why there is this huge interest on looking at catastrophic costs, who is incurring and how much are they incurring, and then what strategies can we put in place to reduce these costs. So there are different ways of estimating the indirect costs here. I won't go much into it, but then it's either multiplying the actual time lost by an hourly rate that is usually the minimum income, or if people can self-report household income, we'll use that household income and then subtract household income before and during treatment. So that's what we calculate as annual as indirect costs. And then there are also different ways of calculating or estimating household income. They can self-report consumption or expenditures or self-reported household income. We use this one, but in areas where it is difficult to estimate household income, maybe because of way too many informal jobs, we can use any of these methods, except this one where they self-report the income. So the bigger picture is obviously to reduce the people with catastrophic cost because of TB. I mean, it's bad enough that someone has TB, but for that TB to further cause them to be in poverty while they're starting at a low level again, it is something that must be prevented. And there are strategies that can be put in place that have been written in this guidance that WHO produced last year, which can be things like insurance, disability grants, vouchers, food packages. However, missing here is what patients can do themselves to something that is more sustainable. So we believe that by reducing this one, we can reduce the TB prevalence, incidence, and death because we have more people with better outcomes of TB. So coming to the findings, well, I'll start with the methodology. This was a cross-sectional design following the same guideline, and we also received ethics approval in 2019 with this reference number. We started our survey preparations by coming up with a technical advisory group that included all of these organizations, WHO, government, with Department of Health here was there, and then Social Security and Department of Social Development. And there were other partners, USAID, we had Hero, Chai, London School, MSF, and it was such a big group with a big number of people that were contributing to the development of this protocol. Quorum was contracted for data collection, and we collected from March to December 2020. It was during the COVID pandemic. Yeah, as you can see, we started right as the lockdown was starting, and we initially planned to collect data from the clinics, but because of patients not being available at the clinics, we had to visit their homes. And the way we were collecting is that for intensive phase patients, we would collect data for patients who are at least 2 weeks into the intensive phase. And then in the continuation, we would collect data if they are 4 weeks into the continuation phase. And some of the data that was not collected because of just the timing of the collection was extrapolated using data of other patients. And we, in terms of our geographical spread, we had clinics across the country. The blue dots would show the drug-sensitive TB clinics because we had 42 clusters and 68 facilities. Some were collecting DSTB patients' data, and other it was collecting only DRTB, the red dots. So it was across the country with 7 each in Western Cape between DRTB and DSTB. KwaZulu-Natal had the most, I think, with the second highest with 12, and the only Limpopo had 1. It was only a DSTB clinic. So we screened 1,214 patients for eligibility, and 60 patients, which is about 4.94%, were excluded. 40 of them did not meet the inclusion criteria, and 20 patients were excluded through data cleaning. Some had verification issues that we excluded. In the end, we had 1,154 patients who were found to be eligible, and of these, 24 did not consent to participate. At the end, we enrolled 1,150 patients into the study across all the facilities in the country. So there was a higher proportion of females both in the DS and DRTB groups. And also in the age group, the most affected age, or maybe the age that we had the most patients, was the 25 to 34 and 35 to 44 years of age, both for DRTB and DSTB. Unemployment rates were very high, up to 46% for DSTB patients and 52% for drug-resistant TB patients. And for those that had completed grade 12 or higher, it was only a quarter for DSTB patients, and slightly higher for DRTB patients, although the differences here were not that significant. And I've looked at this already. And the clinical characteristics, we interviewed more DSTB patients in the continuation phase, and more DRTB patients in the intensive phase. I think this was simply due to that DRTB patients were spending more time in the intensive phase than anything else. And more than 11% of the patients were either relapse or retreatment, and about 60% of the DRTB patients were HIV positive, while for DSTB it was about half. And the DSTB patients had a mean diagnostic delay of 106 days. So this goes back to that point that patients, even in care costs before they are diagnosed, it took them up to 3 months to know that they have TB. So they would be going to several places, and all of these costs, if it wasn't because of TB, they wouldn't have incurred them. So now coming to the objective 1, we wanted to document the magnitude and main drivers of the different types of costs incurred by TB patients and their households in order to guide policies to reduce financial access barriers and minimize the adverse socioeconomic impacts of TB. So health facility visits were generally high, but we found that drug-resistant TB patients had 3 times more visits than DSTB patients. And like the visits, drug-resistant TB patients also lost a lot more time. This was mainly due to them being hospitalized. Caregivers also lost time because of taking care of TB patients. As you can see here, they would be going to the number of hours that caregivers lose as they go to hospital with the patients, as they go for drug pickup and medical follow-ups. And these costs are also now captured as indirect costs because they would have been doing something productive instead of going. Well, it is productive to take a patient to a clinic, but in terms of opportunity costs, it would be they could have been doing something economically productive, and then they earn money because of that. Now, because of going to the clinic and doing all of this, they're losing. So we calculate this as cost. So calculating losses based on an 8-hour working day, drug DSTB patients would lose about 7.7 days, and drug DRTB patients would lose more than a month because of the disease, and that is a lot. And caregivers would lose 2 days because of this. So these losses would translate generally into indirect costs that impact the well-being of these patients. So coming to the total episode costs, drug-resistant TB patients were incurring a higher mean cost as year 17 year compared to 8.9 for DSTB patients. That is, so they would incur at least double the cost of the TB of the DSTB patients. Also, indirect costs are the main cost driver of this. If you look at income loss here, it is the total direct costs are 2,292, while income losses are as high as 6,000, and it is the same or similar for drug-resistant TB patients. It's 3,000 for direct costs here, and it is 14,000 for the indirect costs. So the time that they spend doing all those activities of seeking care, going to the clinic, and so on, it is calculated here as the 80% for DRTB patients and 68% for DSTB patients. Another important factor to consider is the nutritional supplement. This is under the direct medical cost. As you can see, this is the highest cost that is incurred under the direct cost, and it is also things like vitamins, immune boosters that are recommended by peers and relatives. We don't know if this is required or not, but still patients reported themselves as buying these supplements, and they're a big cost driver of this TB cost. Now, coming to the impact of TB on employment status, as you can see, we started with an average. This is for both DSTB and DRTB. This is before the TB episode, around 48% average were unemployed, but after it was 68%. So that is 20% more are unemployed because of TB. Of course, I know there would be questions of maybe this is done during COVID and people were losing jobs anyway. But starting at 48% is also higher than what COVID was. So it was even a very low base. But again, there's no good news here because even everyone was losing. Part-time employees were moving into unemployment, including occasional employees and there were very few that were employed moving to here. Full-time work, times work that is protected by benefits was also lower by 10% here. So this is the story that if you have patients that are starting at this low base and then they have to face so much costs, it will definitely cause problems when it comes to them adhering to treatment, being able to go to the clinics, or even affording to buy food that they need to when they are taking the treatment. So now showing how, again, it's just a graphical presentation of how the costs are distributed. 6.3% are direct medical costs. And this is mainly due to the government policy that gives free medical TB services in the public facilities. So a lot of this is private, where people go to external providers, and we can't control this because this is the choice of the patient. If they want to go to a traditional healer, or if they feel like they have to go to a pharmacy, they will still go, but they will incur this cost. And then there are other direct non-medical costs that they incur this is during the whole episode of TB, as they travel to the clinics and back hospitals. Accommodation, as I say, this is rare accommodation, but at times it's there when people have to lodge at hospitals if they are referred far from their homes. They also buy additional food and their nutritional supplements, but by far the largest is the income loss that they incur because of not being able to work. And then coming to the study objective 2, which is the baseline catastrophic cost. So here, patient and household incomes were, I'll start with income before coming to the actual proportion of patients facing catastrophic cost. Patient and household incomes were already very low before TB diagnosis, and they worsened significantly after. So for context, in 2020, the minimum wage was approximately 3.5 per month. As you can see here, the mean household income, not even patient, the mean household income that was there was less than the individual minimum wage. And the mean individual income fell by almost 50% after TB diagnosis. That is for the individual from 1.6 to 924. Also for the household, it fell by a huge margin again from 3.1 to only 2.6, as you can see for these two numbers here. So again, it's I think it will be clear that with such effects, even factoring in COVID, the impact on income because of the disease would lead to further impoverishment of patients, and well, clearly I would claim that it will lead to poor outcomes. So the main result that we were looking for is the proportion of patients who incur catastrophic costs. So, DSTB patients, they incur it's about 55.56% of drug-sensitive TB patients incur catastrophic costs, and it is much higher for drug-resistant TB patients. It's 64% of the patients in their household incur catastrophic costs. This is in comparison with this indicator of what has been measured in the pooled proportion for all the countries that have done. So we're not really doing that well. And if we want this proportion to be zero, it is a very long way to go before we get to the zero that we want to reach. Well, for the drug, I know the confidence intervals are overlapping, but they're overlapping in the high numbers. All of them are above 40%. So even if they overlap, many of the patients will still be facing at least 20% of their income is being spent on 20% of their annual household income is being spent on just one episode of TB. For the drug-resistant TB patients, this very wide confidence interval was only because of the very small numbers that we had here. If we compare with the global comparing with the global pooled averages here, you'll find that I don't know how clear it will be, but we can compare with countries like Ghana and Mongolia and so on, which are in the 50s. And for drug-resistant TB, we compare with countries like Thailand. But again, comparisons are fine, but if the proportions are high, the majority of the patients or high number of the patients are facing catastrophic costs, as you can see here, and there's a lot of work that is required to get us to the 0% that we are targeting for in the NTB strategy and the Sustainable Development Goals. So when patients face these costs, they tend to find coping mechanisms to take care of these costs that they incur. But just a few were able to sell assets because you can only sell assets that you have. So it's only about 2.5%, the highest DSTV patients were able to sell assets, and not more than 20%, not more than 15% had any kind of saving that was accessible for them to use. Some of them would go for taking loans to cater for this, and these loans are usually those ones that come with very high interest rates that even just make them worse after maybe the treatment is done, and then they have to pay back. And looking at coping mechanisms that are available, that is any of the above coping mechanisms that are available, only a fifth of the patients were able to resort to a coping mechanism to take care of the patients. the rest of the 80% were not able to employ any coping mechanism, which means they had to bear the brunt of these TB costs, which lead them further into poverty. And it doesn't end there, not in money alone. There's also social consequences that that patients in the households have to suffer. About 3% would with they reported divorce or separation. Others had to relocate. School children, up to 5% for DRTB, had to interrupt school. And as we have seen here, many people, almost more than 20% for DRTB, had lost jobs, whether permanent or it was part-time. Food insecurity reported it was much, much higher. About half of the patients that TB patients reported higher food insecurity, about 30% for DSTB. Others reported social exclusion. Half reported being excluded socially for DSTB patients, and 26% for the DSTB patients. Overall, and if you compare, this is a trend that all the bad things are happening, and there's higher social consequences, which are negative, by the way. It's not nothing is positive here. 84% for DRTB patients, and about half of the DSTB patients also reported these negative social consequences. And if someone is facing such would assume someone is facing such a situation, uh, definitely it's also the TB would have to probably not have better outcomes because of all of these consequences that they face. But we also come to the support available for these patients. About 95%, almost only maybe 4% had any form of health insurance. Only 33% accessed social assistance from some government grants, and then 6% received food parcels. We found this through some of the NGOs that were there giving food parcels. And again, this shows that there's little help that is available for these patients, despite the amount of trouble they are in socially and also financially. And so now this graph shows the percentage of TB patients living below the poverty line. More than 90% are living below the poverty line before diagnosis and during diagnosis. I know it seemed like it is slightly lower during diagnosis. Again, the confidence levels are overlapping. But again, if something is above 90%, whether it's lower or higher in both episodes, it is way too high to have so many people living below the line and still face those costs. Now, in the final slides, we're just presenting some of the experiences that we had when we were collecting this data. Maybe to put into context why patients would have to pay so much for travel, and then we care for those costs that patients incur. We had vehicles, but we're even complaining about some of the distances that patients had to travel to get to a clinic. And we also had frequent reports of patients dying, and some of this had an impact on even a toll on our data collectors. Every time you have to go to a household just to show that the disease doesn't just cause costs, but people die in large numbers. So we're getting a lot of these reports every time we do a follow-up visit. So in summary, TB imposes severe financial burden, with many households facing catastrophic costs that exceed 20% of their annual household income. This TB also leads to insignificant job losses and inability to work. Over half of the TB-affected households face catastrophic costs, and is particularly severe for drug-resistant TB patients. Patients also experience job losses, food insecurity, and social exclusion. And in all of this, they have very limited coping mechanisms which force them to deplete savings. They take high interest loans, sell poverty, and all of this lead them further into financial distress. And there's a lack of health insurance, and there's minimal social assistance, which could have allowed them to cope better with these costs, but it further pushes them into poverty. So in conclusion, TB is not just a health issue, but an economic and social catastrophe, and it causes financial ruin for households, such that if we don't control catastrophic costs, the outcomes may never be better. Thank you. This is the last slide. Maybe, yeah, maybe the recommendations or to address high catastrophic costs and impoverishing effect of TB. We called for increasing coverage of social protection, SASSA, UIF, maybe reducing food insecurity and the burden of nutritional supplements by food parcels, facility visits and hours that are spent that they spend seeking care can be reduced by decentralized models of care, and some interventions that are needed to reduce social inclusion, such as social awareness about TB and reduction of stigma. And also because we saw there's a very long diagnostic delay, we need strategies that are we need strategies to reduce so many days and up to 100 days that a patient can wait until they're diagnosed for TB, and implementing monitoring of these interventions. Some of these interventions, we don't know if they work, such as how do we reduce food insecurity? Do we give people food parcels only, or we empower them to do an activity that is more sustainable? So all of this would need to be tested. But at least the WHO came out with a guideline of what countries have come up with to try and mitigate this, and maybe have some recommendations. And I'd like to thank and acknowledge all these organizations and our team that was collecting the data. Thank you.
Thank you so much, Don. Thanks for your presentation. And colleagues, please be reminded to enter any questions you may have under the Q&A tab, or alternatively raise your hand to ask a question or to comment. So we see, Andrew, you've added a comment under the chat. Would you like to unmute? Yes, you may go ahead. Are you able to unmute? Okay, whilst we wait for Andrew to unmute, Chris, you may go ahead. Chris, you should be able to talk now.
Hi. Good afternoon, colleagues. I'm Chris van Rooyen. I'm with the National Department of Social Development. Thanks, Don, for this excellent presentation. I just need to inform the TB think tank that Department of Social Development is now in a process of start to institutionalize the TB response. I'm working in the Chief Directorate HIV and AIDS, and then TB Resort now under our unit. However, we've started the process, and we will have some engagement or workshop in early February with Dr. Mvusi and team. So to start off, my question is to request on if there's a possibility also to include this type of presentation into our workshop. So that's the first one. Then I think what's important for us, it's there now to have basically a mind shift in Department of Social Development, specifically on the specific role of Department of Social Development. Hence, we are clearly, in terms of our strategy for HIV and AIDS, but I need to indicate that we are actually now starting to conceptualize the TB response. And I could see that there's two areas where we could actually contribute to the country responding to the TB recovery plan. The one is on social grants. We started to engage our social security colleagues on this specific issue, and they proposed that we'd like to have a review of the grant in distress. Now, the grant in distress is a general grant, but we would like to have a policy position on specifically for TB patients. So that's our longer policy imperative that we want to change in social development. Then the other one is on food security. Now, as you know, we have our food nutritional centers across these provinces. However, we like to know where are the higher prevalence areas for TB so that our colleagues working in the food security space can also target those areas. So those are the two areas which I think we would like to contribute with the support then of the think tank. And my last point is around the multi-sectoral approach which are proposed in the key recommendations. I think the study highlighted that the impact of job losses is key. How do we bring in Department of Labor? Because I think that's a space where we need to protect also TB patients. I think those are my three inputs. Thank you, Chair.
Thank you, Chris.
Thank you. Can I answer now, or?
Yes, you may.
Well, I think the question was, I think the rest of contributions, but the question was the presentation. Yeah, so this is the DOH presentation, and you can see how we prepared it together with Dr. Mvusi, so it will be available to be presented. We actually have a much bigger report that goes into more detail on specific areas, as you have mentioned about food security, who is most affected, and so on. So yes, it will be available to be presented by at the workshops. Yeah, and also it's encouraging to see a lot of these policy positions that you have mentioned, and because these are the key things that patients were reporting. About food security, having to buy extra food, new supplements, and job losses. And if we have this multi-sectoral approach, I think we can have some progress in reducing the catastrophic costs.
Thank you so much, Don. Andrew, you may go ahead.
Hi, Don. Great work. This is Andrew from the Desmond Tutu Health Foundation. So two things relating to gender. First, I'm kind of surprised at the huge difference between the enrollment of men and women in the study, given the gender differences in all TB, microbiologically confirmed TB in the country. So I'm wondering if you might just be able to address if there might have been any any bias that may have resulted in that skewed enrollment. And the second is, have you done any analyses where you stratify by gender on your work? And the reason why I ask is, in some extensive qualitative work we've done, we're finding that, again, both men and women are experiencing a lot of these situations, especially around stigma and isolation and loss of resources. But it seems that women, because of their stronger connections to their families, or inherently their families are allowing them to be more resilient, whereas men are at a greater risk because they're being socially excluded by their families and social networks. So I'm wondering if you've done any sort of gendered stratification of your results, and if you have, what you might be seeing. Thanks.
All right, no, thanks, Andrew. Yeah, so the first one for the gender, which is why we have more. So these are the people that we found in the households and that we're willing to participate in the study. But if you had looked at the actual statistics, like notifications, you would get more males than females. So I don't know if it's a bias, but it was just how, and we did not have a particular number of males and particular number of females that we needed. So we just said TB patients, whether male or female. But and then when you go out into the household, we would find more females who are willing and available to participate than males. And then, yeah, on the gender stratification, because in the manuscript that we're writing, this is we're going to look at this as well. We don't have the results yet of how it looks like, but it will be available in the manuscript.
Great. And my apologies. Maybe I had misunderstood who was being recruited for this, if it was TB patients or their household contacts. But then on that, have you done any stratification on who that inherent index patient was? Was it male or female?
Okay. No, so this was the index patients, the patients that we find in the household. So the only reason why we went into their houses is because it was during COVID and there were no patients in the clinics. So we had to follow the patients to recruit them from the houses, but not the contacts at all. The contacts would be just some members in the household that would contribute maybe income or some expenses that they incur as they visit. So it was the actual TB patients.
Thank you so much. Ruth Kekana, you may go ahead.
Thanks, Nolwazi, and thanks, Don, for the presentation. I just want to, the comment is not a question, but to what Chris has said, I'm really very happy that the Department of Social Development is onboarding and reviewing their TB response in their contexts. I'd just like to share the experience on the ground. In fact, also responding to the low or the poor access to some relief efforts like your social grants, your food policy for the patients. You know, oftentimes it's not that it's not done at the facility. It is done, just that from the social department, social development, there would be some pushback, and oftentimes clinicians have to fill the form and submit the same application over and over again, motivating why the patient should get such relief efforts. So I hope from here, from the social development would get a positive response in plight to reduce the catastrophic costs. Thank you.
Thank you, Ruth. Dawn, would you like to respond to that, or may I go on?
Well, yeah, I would say from this, the evidence is clear that there's no need for negotiating to give a patient, like TB patient, assistance, because there is no positive indicator in there's poverty, there's job loss, food insecurity, social exclusion. So what else would they need to justify that they are in trouble? So I agree fully with Ruth.
Thank you so much. Nevelyn, you may go ahead.
Thanks, and thanks for a great presentation, Don. I just want to mention that, in fact, we've been aware that this is a problem, so it's great to have the results that show the extent of the problem. I will be reaching out to you for the detail of your project, because we are actually in the process of designing a social impact bond to test some of these strategies to see what really makes the difference to be able to improve treatment outcomes. And we are looking at piloting something that gives us a bit more information, because I think we were able to sort of gather the information from various sources about what is causing the problem, but it's very good to actually have a detailed study that can guide our pilot. We've been working with the National Department of Health and the TB unit, because they are also very eager to stimulate an increase in the treatment outcomes, especially for drug-resistant TB. I'll reach out to Chris. If you have Chris, if you can recommend anybody from DSD that we should be talking to, because we will have that's a steering committee that will be seeing what we're doing and guiding but it will also help them design the policy changes or whatever adjustments that you need, or how to do your planning. So, Chris, if you have anybody specifically that I should reach out to, please put it in the chat. Otherwise, I'll be in touch with you. Thanks.
Oh,
Thank you
thank
so
you.
much. You may go ahead, Don.
All right, no, I was gonna say the same thing. Thank you, and I'm happy that there are a lot of things that are happening around this topic here.
Thanks, and Dr. Lenny Naidu, you may go ahead.
Thanks, Chair. Thanks, Don, for the excellent work and presentation. So my first comment is, you mentioned social exclusion as one of the, sort of impacts. I think, many decades into the pandemics of HIV and TB, stigma and discrimination is still, a huge, huge issue. Access to barrier for care, but also for treatment. I just think, just comment that we don't refer to patients as TB patients or DRTB patients. We try to use non-stigmatizing language. So just a point for that. They are human beings, and we don't refer to them as TB patients. Just during COVID, in the Western Cape, we had this excellent relationship with a DSD where patients that were very ill, hospitalized, we could just fill in a form, electronically, and food parcels were delivered to families. So I just wonder, all the evidence has been there for years regarding the benefits of nutrition, and your work shown that as well. We know the rations trial from India, both on in terms of TB outcomes, but also in prevention of context in TB. So, where are we? I know you've made the recommendation, but how close is National Department of Health together with other departments in trying, like, giving food vouchers to every single client diagnosed with TB or drug-sensitive TB and DRTB? It's just a no-brainer if you look at the cost, compared to hospitalization, use of medicines. We have very high loss to follow-up. Even currently in DRT, in the Western Cape, we have up to 40% loss to follow-up. Again, long treatment outcomes, no access to food, and other, financial insecurity. So how close is National Department of and departments like DSD, but also how do we hold other sort of departments accountable? We need to address social determinants even before patients contract TB. Departments of housing, water and sanitation, economic development. Until we do that, we're still just treating the symptoms. Thanks, Don. I'd like to hear your comments.
All right. Thank you. Well, we recommended multi-sectoral approach for the department, and maybe I won't be able to answer fully on behalf of the department, but I see what Chris has mentioned. I think it's work in progress, and I think he mentioned particularly food security. Probably it is one of the things that will be discussed, because for a patient I'm saying patient again, but for a patient who will be in such a situation, the food parcel is the immediate resolution to their problem than long-term things that they can use to sustain. So probably it's one of the things that will be discussed, and it can be communicated maybe after some discussion from there. Well, they cost a lot of money, but it's better than to have poor outcomes and still spend the money again in the poor outcomes. And I'm glad you also mentioned social exclusion here, because one of the stigmas that we have had is that there's no stigma anymore. And the patients will be saying, yes, there is, and people are saying there's not there anymore. So it makes it just worse that there's the denial of stigma, because we have known TB for so long. I know this is separate from the food security, but it is a big thing that causes people not to want to seek care again, because of some of those consequences that they face. I don't know if I've answered you properly, but I think it's something that is a work in progress with the several departments that Chris talked about.
Thanks, Don. I'm covered. Thank you.
Yes, I see Chris is using.
Chris, you may go ahead and kindly be brief.
Yes, so I think the biggest challenge that we face is to have a clear policy position within the social security setting, or because as you mentioned, the issue of stigma and social exclusion, we at this point in time, the grant of distress, it's just a generic grant that goes to any person that can prove that they are in economical distress. Hence, we don't want to stigmatize people by saying you are a TB patient or living with HIV. And that's one of the challenges. However, we are open, and I think we've also, as Don has said, this is work in progress. We actually want to advocate for a clear policy position from the social sector.
Thank you so much, Chris. I think we can quickly try address the questions or comments under the Q&A. Don, there's a question that says, do you have an idea of the costs associated with a delayed diagnosis?
Yes, what I can do is I can share the report, which has all the tables of cost per phase, and then it will be, I think that is the most comprehensive way. Maybe I can share it with you, and you can share it to the rest of the team, of the group that is here.
Okay. We still have a few questions here. It's a question from Jean-Luc. Jean-Luc, would you like to unmute if you're able to?
Yes, thanks for Don for the presentation. I just wanted to find some clarity in terms of the result, which actually showed a slight improvement in terms of poverty line during the episode compared to prior to the episode. So that discrepancy might not be statistically significant, but is there any confounding factors like the immediate family support when the patient is having TB, which actually could explain why there is such an improvement? I don't know if you did look into that. And in terms of stigma that the patient experienced, I wanted to know if there was maybe further probing to know at which level stigma was actually experienced. Is that a family level, or at a work level with colleague, or at a general community level? That's what I wanted to see, if we can have that.
All right. Yeah, thank you. So for maybe the second one, we in the presentation, we just asked in general if they are experiencing, and we didn't go further into where the stigma is being experienced, because we just called it social exclusion, but didn't stratify further. But it is both family and community that they will be referring to there. And then on the poverty line, again, it's something that we are also trying to figure out why that is the case. Our conclusion was that it is high anyway, but it's not like it went below, and it can only, I think it's only 4 percentage points away from 100%. So it's if you are to round it up, it could be what you have mentioned of family supporting, but we're still looking into the exact reasons why, and that could be something that we want to discuss in the manuscript, because it is the only result that is showing something counterintuitive from what we would expect.
Thank you, Jean-Luc, and thank you, Don. We literally have a minute left. Colleagues, please be reminded to fill in the CPD register that is within our chat. And those who have questions under the Q&A and chat, I can put you in touch with our presenter today, and he can address your questions via email. And if you'd like to see yourself on this platform in the upcoming months, please do email myself at ngosi at tbthinktank.org. And next month, our webinar session, we have Dr. Bay Schmidt, who will be presenting on the evaluation of the influence of the TB think tank on South African policy on the 17th of February. And I'd like to thank everyone in attendance, and thank you to our presenter, and thank you for your time, and enjoy the rest of your day further. See you next month.
Thank you. Bye.
Bye.